welcome to our webinar. I'm sure we will have some additional registrants joining us as we start this evening. But tonight's topic is bladder health for all genders. And we are going to cover issues and topics like overactive bladder and incontinence and urinary tract infections. And we're going to hear from Dr. Mobley that we don't have to live with the discomfort. There are solutions available. So very excited for the presentation tonight. I just want to make sure that everyone knows that we will have a live Q&A at the end of the presentation this evening. So you're going to want to stick around for that because you are going to have an opportunity to ask your most pressing questions, and you can submit your questions throughout the presentation this evening. If you look at the bottom of your Zoom screen, there is a Q&A button. You'll want to use that to submit your questions and not the chat feature. Well, now I would love to introduce Dr. Mobley. She is a board-certified urologist with Urology Austin, and she is nationally recognized for her expertise in minimally invasive treatments for bladder and prostate conditions. And she is the first female urologist in Texas to achieve UroLift Center of Excellence status. I know she is passionate about advancing urology while providing the utmost highest quality of care for her patients. And you can read more about Dr. Mobley at urologyaustin.com on our providers section. But we are so excited to have you presenting to us this evening, Dr. Mobley, and I will pass it over to you.
Thank you, Jamie, and thanks to everybody for joining us today for this webinar. I'm really excited to talk to you guys about bladder health. I'm passionate about bladder health. I spend most of my days talking about bladder health and ways that we can make our bladders function better. We can prolong the healthy lifespan and longevity of our bladders and all the different things that can impact our bladder function over time. And this is both for men and women. I am passionate about both men's and women's urologic care. I treat a variety of different conditions that can affect bladder function for men and women. And I treat a whole lot of other urology problems as well, but I'm certainly very passionate about bladder health. Bladder health matters because it certainly contributes to quality of life. And for any patient that's had urinary tract infections, bladder pain, urinary incontinence, bladder cancer, bladder prolapse, there's a variety of different reasons and symptoms that one can have that can really impact their quality of life related to bladder health. Diseases of the bladder contribute to significant morbidity and healthcare spending dollars across the United States and across the world. Bladder cancer is the third most common solid cancer in the United States, and many bladder issues are treatable, especially when caught early, but lots of patients don't realize that their bladders are affected by other conditions, that there are treatable conditions that they are dealing with, and that they could come to a urologist and get many of these issues sorted out. So that's what I'm here to briefly touch on. Really, the bladder, bladder health is a really big topic, so I kind of had to focus on a few things, but there's so much more to bladder health. I could spend a few webinars talking about it. What I'm going to focus on today is urinary incontinence, both for men and for women, urinary tract infections, and bladder cancer. Urinary incontinence is, there's multiple different types of incontinence, and I'm really going to focus on the main few types of urinary incontinence. I'm going to briefly review treatment options for urinary incontinence and all the reasons why both men and women can have urinary incontinence. I'm going to talk about urinary tract infections because they can impact both men and women, and they are a significant source of healthcare spending and a significant source of morbidity and even mortality in elderly patients. And then we're going to focus on bladder cancer. Bladder cancer, again, is the third most common solid cancer in the United States. And a lot of bladder cancer goes undiagnosed for way too long because patients aren't aware of the symptoms to look out for. And when caught early, it's a very treatable condition. And actually at Urology Austin, we're very lucky to have a very robust research department, and we do a lot of clinical research, especially in the bladder cancer space. And we've really been seeing the paradigm shift in bladder cancer care over the last few years. And it's been really special to be a part of that because we are participating in those trials that are bringing new therapies to patients that have never been available before and are extending quality of life and lifespan because we're treating bladder cancer better. So I'm going to give you a brief overview of the anatomy and physiology of the urinary system. So up top, we've got our kidneys, and the kidneys are what filter blood and make urine. And then the urine runs down the ureters. These are the tubes between the kidney and the bladder. And most people have two ureters, one from each side, but occasionally you'll have patients that have two on one side or two on both sides, but one each is the standard. Those ureters then insert into the bladder. And the bladder is both a storage unit, it's got to store urine, but it also is a muscle that has to contract to push urine through the urethra, which is the tube between the bladder and the external world, to empty its contents so that the bladder can fill up again. And this is a very complex interplay between the brain, the spinal cord, the pelvic nerves, and the bladder. The bladder is totally controlled by the central nervous system. You can't will it to work. That's why when you got to go, you got to go. And sometimes you can't hold it because the brain is sending a signal down to the bladder that it needs to go, maybe even before you're in a position where it's time to go, like on the toilet with your pants down. So a lot of people think, oh, maybe it's just in my mind, maybe it's in my brain, maybe I can do some bladder retraining. But the reality is that holds true for a few patients, but a lot of patients really cannot control this problem when they've got some overactivity symptoms. And it's because it's a miscommunication between the brain, the spinal cord, the peripheral nerves, and the bladder. So for the bladder to work normally, what has to happen is it fills with urine from the kidneys. And as this happens, the pelvic floor should be tight. The sphincter muscle that wraps around the urethra should be tight. And that allows the urine to, fill within the bladder without you just leaking constantly. There are sensory receptors within the bladder that are constantly sending signals back through the spinal cord up to the brain, letting the brain know when it's starting to get full. And when you're not that full, normally you shouldn't notice that there's urine in their bladder. But as the bladder starts to get more full, these signals will start to accumulate and the brain will send signals back down that's telling you, hey, you're getting a sensation. It's getting to be time to find a bathroom. So that's when you're driving down the highway and okay, the next exit, we're going to pull off on that, right? You should be able to get off that exit, walk into the bathroom, wait your turn in line, then get in the stall, pull your pants down and go. But sometimes that signal is coming on so strong and the bladder's starting to squeeze before it is really supposed to, or before you're in a socially acceptable position for that to happen, like in the restroom. So that's really where we get into some overactivity, which I'm gonna hit on pretty hard in just a minute here. But the normal function would be as the bladder's full, this signal system from between the brain and the bladder starts to work. You get that signal you need to go. You go sit down on the toilet or stand up if you're using a urinal. Your pelvic floor muscles should relax. Your bladder should then squeeze to push the urine through the urethra. And then it should squeeze long enough and hard enough for you to empty the entire contents of your bladder. And then the bladder muscles should relax again. And then the pelvic floor should tighten again. And the cycle starts over. So that's the total micturition cycle is what it's called. In patients that have urinary incontinence, we really focus on the three main types, and there's urge urinary incontinence. Urge urinary incontinence classically is associated with overactive bladder, with the hallmark symptom being urinary urgency, that sudden compelling desire to have to use the restroom. Some patients can have urgency without frequency, meaning having to go to the bathroom a lot. Some people have urgency with frequency. Some people can have frequency without urgency. And then some patients feel like if they don't make it to the bathroom, they're going to have an accident, but they don't. That's called overactive bladder dry. And some people are going to have an accident if they don't get to the bathroom fast enough. And that's overactive bladder wet or urge incontinence. And it's kind of a spectrum. There's also stress incontinence. Stress incontinence is a different type of incontinence, and it's really related to the urethra. The urethra is, again, the tube between the bladder and the external world. And there is a sphincter muscle that surrounds the urethra. And when there's external pressure being pushed on the bladder, so you cough or you sneeze or you pick up something heavy, any sort of internal intra-abdominal pressure is going to press on the bladder because it's the most dependent thing down in the pelvis. This external force, normally when that happens, your pelvic floor muscles in your sphincter tighten and the urethra shuts down pretty hard, and that keeps your urine in. But for some people, their sphincter muscles are incompetent, or there's deficiency there, or maybe after childbirth in women, or pregnancy, or chronic coughers, smokers, there can become laxity in the pelvic floor muscles and fascia, and the urethra falls out of its normal position and it can't close properly. So stress incontinence is leaking during those activities, that cough, that sneeze, that jump, and it's usually smaller squirts of urine that come out. And then it stops because the intra-abdominal pressure has normalized again. That is typically more of an anatomical problem of the urethra or the sphincteric muscle, whereas the overactive bladder is more of a physiologic problem of the bladder. Again, a brain signaling issue, whereas this is more of an anatomical issue. So the real causes of why these happen are slightly different, though there is some overlap. We typically will see, again, childbirth, menopause in women, or perimenopause can be a cause for stress incontinence, and overactive bladder for that matter in women. Aging is a natural part of aging. We'll see some urinary incontinence develop, especially in women. Same thing with overactive bladder. Smoking is a big risk factor for stress incontinence because it does affect the integrity of pelvic floor and any connective tissue for that matter. And so it causes weakening of the pelvic floor muscles, the vaginal wall, and that can lead to more leaking problems. Chronic coughing, excess weight or obesity. In men, radical prostatectomy or any surgery that's performed on the prostate can put those sphincteric muscles at risk because the sphincter sits right on the outside of the prostate in men. Women, of course, don't have a prostate. In the overactive bladder urge incontinence, we see similar risk factors, but there's a few other subtleties here. Nerve damage, bladder muscle overactivity from dietary irritants, especially coffee and tea and soda. Really spicy foods for some people can do it. Carbonated water, it's not just sodas. Acidic foods, citrus-based products, vinegar-based products. Not everybody's sensitive to these things, but these are the common offenders that some people that are more prone towards an overactive bladder, these may aggravate their symptoms, make it worse. Chronic inflammation can make overactive bladder worse. Menopause, of course, can make it worse. And then for men, especially who deal with this problem, chronic outlet obstruction is a risk factor for overactive bladder and urge incontinence. And the most common source of outlet obstruction is going to be enlargement of the prostate, which we'll get to in a little bit. The third type of incontinence that I want to mention is overflow incontinence. This is more common in men than women, but it can happen in both genders. The reason it's more common in men is that overflow incontinence typically occurs when a patient has retention of urine. That means they are not able to empty their bladder. Sometimes not empty it at all. Sometimes they're inadequately emptying, so they've got some ability to void, but they're really only voiding a very small portion of their total urine volume. So their bladder's constantly full. And when the bladder gets really full, the urine just kind of leaks out. Basically, it finds whatever exit point it can, and you're just sort of leaking off the top. So overflow incontinence is really a scary thing when you find that, because that patient may have so much back pressure within their bladder that urine's not able to come down the ureters from the kidneys anymore. And these patients are at risk of going into renal failure, definitely acute or chronic renal failure. And it's quite shocking how many times men come into my clinic not realizing that they're in retention and that they've been just having a little bit of leakage, didn't think much of it, come to find out that they've got 1 liter, 2 liters in their bladder that they didn't even sense. And so that's a scary one when that can develop and the patient doesn't even realize it's happening. I seriously have had many patients come in and tell me, man, I thought I was just developing a beer belly. And when I put a catheter in to drain that urine out, all of a sudden they had a flat stomach again and they had no idea. So, if you're out there and you feel like you're dribbling, you're not emptying very well, maybe you don't notice you're not emptying, but something's just not right, you've got a little pressure down below, it's certainly worthwhile to check in with your urologist and make sure that you don't have a problem with retention and are experiencing overflow incontinence. Other reasons that patients can develop that are spinal cord injuries, neurologic injuries. Diabetes is actually a really big risk factor for all of these problems, but especially the overactive bladder, urge incontinence, and the overflow incontinence, because diabetes can affect nerves. When your blood sugar levels are really high, you know how, for those of you that have diabetes, you might have heard that you can develop peripheral neuropathy. You get that numbness and tingling and pain in your lower extremities. You can get retinopathies. You can get nephropathies. Well, you can get a cystopathy, which is basically abnormal function of the nerves that control the bladder. And we just talked about how basically the central nervous system is completely in control of the bladder. If the nerve endings that control bladder function are being adversely affected by the diabetes, we will absolutely see worsening in the overactivity symptoms. And as it progresses, we'll actually see the bladder stop being able to respond to the nerve input, and it will stop squeezing. It'll stop functioning. Those patients can develop retention. As we age, we all naturally lose some of our nerve input to the bladder. So there is an aging phenomenon with relation to decrease in bladder function over time as well. So that's why it's really important, especially in men who have a compounding issue of the prostate becoming enlarged, to make sure they get this problem taken care of early, because we can't stop the aging process, but what we can stop is the obstructive process. And we don't want that to compound the natural aging process. So, I know one of my partners gave a recent webinar about urinary incontinence, really more focusing on the women's side. So I don't want to hammer that too hard, because many of you may have already tuned into that, or you can go back and look at it. But I do want to just touch on a few of the treatment options that we have for urinary incontinence, and make sure we also mention some of the things that are also pertinent to the men in the room. So for stress incontinence, dietary modifications are important. Again, cutting back on the coffee, the tea, the sodas, things like that can help. Pelvic floor physical therapy is a very reasonable and very efficacious treatment option for many patients that have milder stress urinary incontinence, especially if they've got some sphincteric insufficiency or their sphincter muscles aren't very strong and they need some directed help with strengthening those muscles. They also can help lift and tighten. So if you've got milder hypermobility, maybe after childbirth, and there's a lot of pelvic floor trauma that goes on with that, pelvic floor physical therapy is very helpful, and it never hurts anything. It typically helps, it can resolve the problem, but if not, it helps whatever else next step is to come. Mona Lisa therapy is a carbon dioxide fractionated laser therapy that is FDA approved for a variety of different issues related to women's pelvic floor health, but it is FDA approved for stress urinary incontinence, milder forms of prolapse, which is where the vaginal walls have become lax and are falling. It is helpful for overactive bladder as well. So, this is a nice non-surgical in-office-based treatment option for the right patients. The downside to it is that it's not well covered by insurance. The vast majority of patients don't get insurance coverage for this, and it's not insignificant in terms of the price. But for a lot of patients who are wanting to avoid surgery or do more conservative things first, this might be a really nice option. There's also bulking injections. The most commonly utilized bulking injection currently, and the one that I prefer, is called Bulkamid. This is a water-based gel that's injected under the mucosa of the urethra. Think about, those people that you see that have really thick, full lips. They go get their lips injected. It's like lip filler, but for your urethra. And what it does is it creates more outlet resistance. So when I inject the gel around the urethra, it creates these little cushions. And those cushions come together and they basically make the lumen, or the channel of the urethra, more narrow. The gel's moldable, which is nice. So if you overdo it, you can always get somebody out of trouble. You're not going to put them into persistent retention with the bulking injections. And it's non-particulate. It doesn't migrate. And for patients that it works in, it tends to work ongoing. There's 8-year published data showing that it continues to work for those patients out through 8 years. Doesn't mean it's going to stop at 9, but that's how long the data has been published. There's also mid-urethral slings or pubovaginal slings. The most commonly utilized sling for stress urinary incontinence is a mid-urethral sling. This is a synthetic mesh sling that is placed under the urethra to sort of lift and support it, so that when patients cough or sneeze or laugh and their urethra starts to fall, it falls into it and compresses it, and that allows it to shut. And these can be used for both men and women. The slings themselves are slightly different, but they are useful for both men that struggle with, for instance, post-prostatectomy incontinence, as well as women who have the sort of standard stress urinary incontinence. Pubovaginal slings are slightly different. They're typically placed a bit tighter at the bladder neck for patients with much more severe incontinence or who may not be able to tolerate a synthetic mesh sling. And for men, actually, and women, they're just not as frequently utilized for women, but frequently utilized for men are artificial urinary sphincters. These are sphincters that we place around the urethra that are a hydraulic mechanical device that there's a pump placed into the scrotum, a reservoir in the lower abdomen, and this thing is constantly full, acting as a sphincter for the patient who may have had a prostatectomy and developed incontinence after the prostate surgery for prostate cancer, typically. When they need to use the restroom, there's a little button that they press in the scrotum that pushes the fluid from the reservoir from the cuff surrounding the urethra into the reservoir, and that allows the cuff to deflate. Now they urinate, it takes a minute or two and it refills, and they go back to being continent. So that's a really nice option for men that are struggling with more severe incontinence after their prostatectomies. For overactive bladder and urge incontinence, again, dietary, lifestyle changes, pelvic floor physical therapy all play a big role. We get into oral medication therapies. You notice there's really not an oral medicine that helps with stress incontinence, but it's a much bigger treatment option for patients with overactive bladder urge incontinence. And again, it's the whole play on trying to affect the nervous system and the neurotransmitters and the receptors on the bladder that control the bladder function. There's really two main classes of drugs. There's beta-3 agonists and there's anticholinergics. Beta-3 agonists, there's two on the market. There's Gemtesa and there's Mirabegron or Myrbetriq. Mirabegron is the generic form of Myrbetriq. It's been around for, I don't know, 14, 15 years at this point. Gemtesa around 4. Gemtesa does not have a generic, and it's a great drug. They're both great drugs. They work to keep the bladder in the more relaxed state, which is very helpful because it's not impairing contractility. We want our bladder to contract when it's time to contract. So theoretically, keeping it in a nice relaxed state when it's meant to be relaxed makes a lot of sense. They also have much fewer side effects than the other class called anticholinergics. The anticholinergics, there's many of these on the market. They've been around for a much longer period of time, and they can work well. There is data showing that they can work well, but the way that they work is different. They block the acetylcholine receptor on your bladder. That is the acetylcholine is the neurotransmitter that comes from the brain down to the bladder and tells your bladder to contract when it's time to go. You block that receptor and it should inhibit that contraction from happening. But the downside of these drugs is that there are acetylcholine receptors on many other organs controlled by the parasympathetic nervous system, just like the bladder. And that includes the colon, so that can lead to constipation. The lacrimal ducts, that can lead to dry eyes. The salivary ducts, that can lead to dry mouth. And there are acetylcholine receptors in the brain. And so there is a concern or a risk that we could see cognitive slowing, cognitive decline, maybe even the development of dementia from these drugs. Now, there's a lot of nuance to that conversation, and it's controversial, and we don't have definitive data that shows that, but there is a concern there. So for patients who are maybe in an older age range, we really try to avoid those drugs. For anyone that has pre-existing constipation or dry eyes, dry mouth, glaucoma, there's a lot of reasons why we might want to avoid those drugs. And we would primarily choose the beta-3 agonist. So that's a decision that you and your doctor would need to come up with, whether you are or are not a good candidate for those drugs. And if not, and if you've tried and failed drugs, then we would move on to other procedural interventions. These are some of my favorite things to do because they work very well, and these really improve quality of life for patients. Some of our patients are just miserable wearing multiple pads per day or diapers per day, getting up so much at night that they can't get a good night's sleep, not able to go out to dinner or a movie with their family or their grandkids for fear that they're going to have an accident. These are huge quality of life problems, and we can help. And the really cool things about these procedural interventions is that typically they work better than the drugs. They get patients off drugs. It's not to say that some patients don't have severe enough symptoms that they don't need both or multimodal therapy. That can happen for sure. But these give us other alternatives that are in many ways safer than the drugs. They don't cause polypharmacy. It's not another drug that you're adding to the list. You have to worry about drug-drug interactions, and they work quite well. Now, they are quite different options, and so each individual patient will have to decide what fits into their comfort zone best, looking at the risk benefits. But briefly, Botox is a potent paralytic agent. We use it in teeny tiny doses, injected directly into the bladder muscle in a quick office-based procedure. It can be done in the operating room, but I'd say about 95, 99% of the time, it's able to be done in the office for most patients in about a 2-minute office-based procedure. We inject the medication around the bladder, and within 1 to 2 weeks, that bladder will calm down. The risks associated with this can include a urinary tract infection, just because we are putting a camera in and doing an injection, a small chance of a little bit of blood in the urine. You may have a little burning with urination for a few days, but the big thing people worry about is possibly the development of retaining urine or incomplete bladder emptying. It is, for that matter, a paralytic agent, and we're using it in teeny doses. The chance of a patient having retention after Botox, where they might need to catheterize themselves or have a catheter put in, if you look straight at the data that got FDA approval for Botox, it's about 6%. But in the real world, it's more around 3 to 4%. The reason I say there's a difference there is that with any clinical study, they will have a set guideline where they say any patient who's retaining urine after the Botox injection above X threshold, we're going to have them catheterized. But in the real world, some patients maybe do fine if they're retaining a few hundred cc's of urine, and some patients may not. So it's a real individualized conversation with the patient, and there's been follow-up published data showing that in the real world, probably only about 3% of patients will experience such a side effect. The good news is that Botox does wear off. It's not permanent. Love it or hate it, it is going to wear off. And so if it's working well for you, you need to understand that it's not a permanent solution. It is something that we have to maintain. And on average, it's done about every 6 months. Some people will get a little more. Some people can squeeze out maybe 9 months or even 12 months out of it, but the average is 6 months. So there's a pro and a con to that. Each individual will have to decide if that's something that they would like to try. And if you're getting Botox in other areas of your body, you do need to let your doctor know, because we can only give a certain amount of Botox at any one time, just to keep you under the safe dosing strategy. We're going to move to sacral nerve modulation, which is another excellent treatment option for patients with overactive bladder, urge incontinence, urinary urgency frequency. But this type of therapy also has the ability to help patients that cannot empty their bladder, that struggle with incomplete bladder emptying. And it also is actually FDA approved for patients with fecal incontinence. Fecal incontinence, for those of you who are not aware, is when you leak stool. That's also an extremely common problem. 1 in 12 Americans has it. Many people don't talk about it because it's so embarrassing for them. But we definitely have a great treatment option in sacral nerve modulation where it helps 80% of patients. So sacral nerve modulation is an implantable nerve stimulator. I know that sounds scary for a lot of people, but it's similar to maybe a pacemaker for your heart, but this is going to be a pacemaker for your bladder or your bowel. It's just going to get things working in rhythm again, get the brain-bladder communication or bowel-brain communication working in sync again. And these are quite successful for patients that have those overactive bladder, urge incontinence, or fecal incontinence symptoms. Tibial nerve stimulation or implantable tibial nerve stimulators are also a play on nerve modulation for impacting bladder function. There's a few on the market now. They're FDA approved specifically for patients that have urge incontinence. And these are actually little stimulators that are placed in the ankle. And believe it or not, there's a nerve that goes all the way up from the very lower part of the ankle, all the way up to the pelvic floor. And basically, the way I kind of explain it to patients that makes sense is it intersects and crosstalks with the main bladder nerve. And through intermittent peripheral stimulation of that tibial nerve, we can see improvement in urinary urgency, frequency, and urge incontinence, just like we can with the sacral nerve modulators. So that's another nice option for patients who maybe wouldn't want to get a sacral nerve stimulator for whatever reason. Okay, I'm gonna, briefly, I'm gonna talk about overflow incontinence, and it kind of runs into my next slides where we talk about enlarged prostate. But again, for overflow incontinence, the main things here, or you need to, number one, relieve whatever the obstruction is. Whatever is making it so the patient cannot urinate, whatever blockage is there, whether it's a prostatic enlargement. For women, it could be prolapse, really significant pelvic organ prolapse. It could be urethral stricture disease. So whatever's causing the blockage, we first need to get that blockage taken care of. Then we see whether or not the patient's able to start urinating. And if not, then we would again come back to the sacral nerve modulator. That's the implantable nerve stimulator that can not only help people who are urinating too much, but also help people that can't urinate well enough. Okay, we're going to switch gears here. This is just a schematic showing prostatic anatomy and how it relates to the bladder. So the prostate is this gland right here. Hope you guys can see my cursor. The urethra runs right through it, inserting into the bladder. There's a bladder neck sphincter muscle right here and the external sphincter muscle right here. This is the sphincter muscle that men can contract if they want to stop their flow of urine. That's the one they have volitional control over. The bladder neck sphincter is actually not under our voluntary control, just like the bladder itself is not. As men age, their prostates get bigger, and the bigger the prostates get, typically it narrows down the urethral channel. The bladder muscle is a smooth muscle. The smooth muscle of the bladder is very different than your skeletal muscles, like your biceps or your quads or your hamstrings. Those muscles are skeletal muscles. Skeletal muscles love to work against resistance. When you go lift weights and work out, those muscles get bigger, stronger. We call that hypertrophy. When those muscles hypertrophy, they get more efficient. The bladder, if you want to think of it this way, it's a lazy muscle. It does not want to work against resistance. When smooth muscle, like the bladder, and by the way, the heart is a smooth muscle, and they're very similar organs. When smooth muscle is asked to work against resistance for a chronic period of time, over years, decades, whatever, the muscle will hypertrophy, just like other muscle, but the morphological changes in that muscle, the actual cellular structure of the muscle will deteriorate. We start to see collagen being deposited into the muscle, but collagen cannot expand and contract like a normal bladder muscle cell can. So what happens is the bladder becomes very thick-walled and trabeculated, and it can't expand like it's meant to. It can't hold urine without generating high pressures. It also can't contract like it's supposed to when that muscle deterioration occurs. So we really want to understand when a patient is dealing with an obstructive problem. And again, most commonly in men, it's an enlarged prostate, but it could be urethral stricture disease, or for women, there's urethral stricture disease or other reasons that they can have an obstruction. And that really impacts the long-term bladder health. While BPH is not cancer, it definitely affects men's quality of life, and it is more common than cancer. Prostate cancer is very common. It is the most common solid tumor in men, but 40% of men in their 50s will have an enlarged prostate. We're not talking prostate cancer, just the enlarged prostate. And over 60% of men in their 60s will have BPH. And for every decade a man gets older, their chances of having enlarged prostate and symptoms related to that will go up concurrently. This is these are actual pictures that you can see of a bladder. Okay, we're looking in with the camera into the bladder, and the picture on the left is a nice smooth-walled, healthy appearing bladder. And this is a patient now who's developed these thickened bands. Those are called trabeculations. Those are signs that the patient's developing chronic bladder outlet obstruction, and you can see that visually when you pass a camera in. You can see this happening, and it's very helpful to show men this so they can kind of understand their situation. This is more significant trabeculations, and then you can actually start to develop what are called cellules and diverticulum. These are little outpouchings on the bladder where the muscle itself has split, and now it's just basically a mucosal pouch there. When that happens, there's nothing behind that pocket of mucosa holding the urine to squeeze and push the urine out. So that can contribute to incomplete emptying as well, and bladder weakness. If a man lets the prostate get too big and the bladder deterioration happen, it goes on so long, before he comes in to see us, what I tell them all the time is, look, I can give you a pipe. There are many ways that I can open up the urinary channel. I can open up the urethra 17 different ways, but I cannot give you a new pump. Okay, we really need to make sure that we are addressing the obstructive problem early, because if the bladder muscle becomes damaged and it gets past the point, I mean, it can get past a point where there's really not a whole lot that we can do, because once that bladder muscle function's gone, it's gone. There's no getting it back. So we want to intervene early before it gets to that point. Okay. So when I see men in the office, I oftentimes tell them, hey, I think next time you're in here, or if you're willing to do it today, we got time, we should probably take a look inside your urethra, take a look at your prostate, see the prostatic anatomy, get a look at your bladder, see what your bladder's looking like. I show them these types of pictures in the office and say, I really need to know what your bladder looks like so that I can help you make the best decision for your prostate and your bladder. And there's a lot of subtleties to the decision on which procedure is going to be best for the right person. I take a lot of time going through that with my patients to make sure that we pick the right procedure for their prostate anatomy, their bladder health, and what their goals are, whether it's, you know, their sexual function goals or urinary function goals. We take all that into account to pick the right procedure. But the best way to do that is to have really good diagnostic information. And that comes from a cystoscopy. And typically we're going to want to get an ultrasound of the prostate or some sort of an imaging study to measure the size of the prostate so that we can come up with a game plan. We measure urinary flow rates, and we measure how well is a patient emptying. We check what's called their post-void residual. That's how much urine they leave behind once they've emptied their bladder. When the prostate gets enlarged, the most common symptoms that men are going to come to us with are post-void dribbling, urinary frequency and urgency, weak stream, intermittency in their stream, so stop and start going, straining to urinate, and nighttime urination, excessive nighttime urination. So if you're having any of those symptoms, that would be the time to go ahead and come in, find a urologist if you don't already have one, or make an appointment with your urologist to talk to them about what workup you might need to have done to try to understand whether or not you're dealing with one of these types of problems. What will happen as the problem progresses is those symptoms sort of morph into urgency-related incontinence, just like, you know, what women can have, and eventually incomplete bladder emptying and full-on retention of urine. And we really hate to catch a patient too late when they're already in retention, because their outcomes are just not as good if they've already been in retention. Some patients will develop retention after surgery or develop retention with an episode of constipation. If you have something like that happen, that's a real big warning sign right there. If it happens once, it's very likely to happen again. And it's a sign that there's some underlying problem going on. So even if you had something like that happen and you think, oh, there was a reason for it. I had surgery, or I got really constipated, or I took some allergy medicines, which can also do this. It may be a reason to go ahead and get early screening. So these are the symptoms that we just kind of went through. But bottom line, if you're struggling with any of these, I'm happy to see you. It's one of my favorite things to treat, but we got many doctors at Urology Austin who are very good at treating BPH and getting this workup done for you. Okay, I'm going to switch gears here for a second because I gotta stay on time. I could talk about this all day. Urinary tract infections. So a urinary tract infection is technically an infection in any part of the urinary tract, but most commonly that's going to be the bladder. We call that cystitis, or the kidneys. That's pyelonephritis. UTIs, by definition, are characterized by both clinical symptoms and microbiological evidence of an infection. That means you have a urine culture or urine PCR that shows bacterial presence and you have symptoms. Notably, and I want to make this very clear, bacteria in the urine without symptoms is very common, and it has its own name. It's called asymptomatic bacteriuria. It is a well-established thing. I'm not even going to call it disease. It's a thing. It's not a bad thing. It is not considered a UTI, and it should not be treated. There are very specific circumstances in which that's treated. That is, if you're pregnant, or if you are going to have a urinary tract surgery where we are literally inside of your bladder or your kidneys. Outside of that, and maybe some other very esoteric situations, we don't want to treat for findings of bacteria in the urine if you're not having symptoms. That only creates more problems, and we see it all the time. And once you go on an antibiotic for, let's say you go for your annual visit, your primary care doctor checks your urine and they say, oh my gosh, you have a UTI. Well, I'm not having any symptoms, doc. Here's your antibiotic. Don't take it. If you get that antibiotic, what will happen is a few things, or what can happen. It won't always happen, but what can happen is you destroy your normal gut flora, you destroy your normal bladder flora or your normal vaginal flora. And all of a sudden you weren't having symptoms and now you're having symptoms because that bacteria that's in there is actually serving a purpose for you. You're living in a state of kumbaya, state of symbiosis with that bacteria. There's no need to disturb it. There's no need to try to get rid of it because oftentimes we won't be able to get rid of it, but you kill off the good bacteria that's sort of keeping the balance and the bad bacteria can take over. Not only that, but antibiotics have a lot of potential side effects. There's a lot of drug interactions with other medications on the market that patients may be on. They can cause tendinopathies, they can cause lung issues, they can of course cause diarrhea and yeast infections and C. diff colitis. And the most scary thing is that we're seeing more and more multi-drug resistant infections coming, and that's because too many people are overusing antibiotics. The prevalence of UTIs is really quite common. You know, the lifetime risk of estimates for UTIs for women is around 40 to 53% of women will have a UTI in their life. 12 to 14% of men will. The reason men are less likely to have UTIs is that they have a shorter, women have a shorter, straighter urethra. And we also have a urethra that's very close proximity to the vagina and closer to the anus. Men, of course, don't have that same anatomy and they've got a much longer urethra and a prostate that's in the way. So the prostate helps them in that scenario. That's about it. In the USA, multiple billions of dollars are spent on UTIs alone every single year. And the risk of urosepsis in postmenopausal women is about 1 to 2%. But if sepsis develops, this is infection now in your bloodstream, making you very sick. Mortality, risk of death, can exceed 30% in hospitalized elderly patients. This is no joke. And, you know, I kind of went over this briefly, and for the sake of time, I'll let you guys read that. But one of the most critical things that you can do to help prevent UTIs is stay well hydrated. That's men and women. Avoid constipation. That's men and women. Make sure that if you've got any issues for the men in the room where you feel like you're not emptying very well, that you get evaluated to make sure you're not retaining urine, because retaining urine or stagnant urine in the bladder, whether it's a man or a woman, is a risk factor for developing chronic infections. And the single biggest risk factor for women is menopause. And there is just a litany of data showing how effective vaginal estrogen is for this problem. In fact, there is an entire guideline that was just published earlier this year by the American Urological Association highlighting the importance of vaginal estrogen for something called genitourinary syndrome of menopause. And one of the symptoms of genitourinary syndrome of menopause is recurrent urinary tract infections. And vaginal estrogen is a lifesaver, literally a lifesaver for people. It is safe. The FDA just last week got rid of all the black box warnings on estrogen products for women. They shouldn't have been there. There's a lot of fear mongering, those labels created for women. Estrogen, especially in the vaginal form, is very safe. We even feel safe enough using it in breast cancer patients. Of course, we discuss that with them and their oncologists when need be, but it is that safe that we feel comfortable using it even in patients with breast cancer. There is data showing that women who are on vaginal estrogen have less rates of breast cancer, and when they get it, they die less often from it. So, you know, I put it on my face. When I get to that age, I'm going to use it wherever I need to use it. But vaginal estrogen is safe, and I'm a big fan. Okay, last thing here. Wait, before I move on, urinary tract infections, 2 other quick things. There are a couple supplements on the market that you guys should consider if you're struggling with recurrent urinary tract infections. One is something called proanthocyanidin. This is part of the cranberry that's very helpful for urinary tract infection prevention. You want to get a supplement that's high quality. Look for something that's what's called NSF certified. That's National Supplement Foundation. That means that the quality of the product is there. You know, they get random spot tested, audited. There's no impurities. The amount that they say is in their supplements in there. You're getting what you're paying for. Not all supplement companies are NSF certified. So I would find somebody that's NSF certified. 36 milligrams of proanthocyanidin minimum per day is what's recommended. Another high quality supplement that can help is called D-mannose, and 2 grams of D-mannose per day. There are some supplement companies that combine the 2 into 1 as well. Okay, last but not least, we're going to talk about bladder cancer. So bladder cancer, 85,000 new cases in the United States in 2025 alone. There's going to be an estimated 17,420 deaths in the United States from bladder cancer. The lifetime risk of bladder cancer is about 2.1%, and it's 4 times more common in men than women. The average age that a patient is diagnosed is around 73 in the United States, and more than 90% of patients that develop bladder cancer are diagnosed after the age of 55. So these risk factors are going to be age, especially greater than 55. Men are clearly at higher risk than women. Some lifestyle and exposures can increase risk. Lifestyle factors include smoking. This is the single largest modifiable risk factor for bladder cancer. Occupational exposures such as painters, patients that are individuals that work as firefighters or that are exposed to a lot of smoke or nitrosamines or petroleums or paints, even people that work in a hair salon, those types of things, they're at higher risk because of the chemical exposures. Chronic urinary infections are a risk factor, as is history of pelvic radiation therapy. For instance, somebody that got radiation for cervical or uterine or colon or prostate cancer is going to be at slightly higher risk for bladder cancer. Early detection is key. Most bladder cancers are caught early, thank goodness. And while the tumor, it remains what we call non-muscle invasive. So this schematic here on the screen shows the different stages of bladder cancer. And you can have bladder cancers that are just on the very surface of the mucosal lining of the bladder. They can start to get into that first lining, and then they can get into the muscle. And when they get into the muscle, that's where there's a big fork in the road in terms of bladder cancer management. That's a lot more serious of a disease. It's not to downplay non-muscle invasive bladder cancer, because it's a serious disease as well. But once it gets into the muscle, we're getting into much more aggressive treatment options, considering chemotherapy, immunotherapies, and possibly removing your bladder. So we want to catch this early so we can try to save the bladder. We want the bladder. We don't want to have to take bladders out and give patients neobladders or give them conduits where they have to have a bag. We'd like to catch it early. And with, proper screening and with proper referrals to urology when patients are developing gross hematuria, that's visible blood in the urine, that's critical. If you got visible blood in your urine, you need to be seen by a urologist. We'll do an entire evaluation to understand what caused that. Now, maybe it was just a urinary tract infection. Maybe it was a kidney stone, but you never know. And we always want to rule out bladder cancer or kidney cancer for that matter when somebody's got visible blood in their urine. For women that are having UTI after UTI after UTI, we want to see those patients. We want to put a camera in their bladder and look, do they have bladder cancer? That is a common risk factor. And unfortunately, a lot of patients are seen at an ER and told, oh, you probably just have a urinary tract infection, but they have blood in their urine. They never told to see a urologist. And we miss bladder cancer when it's, smaller, more easily treatable in those types of scenarios. When we diagnose a patient with non-muscle invasive bladder cancer, we have to have close follow-up with them. We're going to get to know each other very well. We're going to be looking at your bladder very often to make sure they don't come back, because they are prone to recurrences. So, really the keys, the warning signs to recognize is blood in the urine, urinary frequency and urgency, especially if it's something that's just new out of the blue for you. It's not something that you've kind of struggled with or it's slowly progressed over time, something that's kind of out of the ordinary for you. Get seen about it. Make sure it's not a UTI. Make sure it's nothing else. If there's blood in the urine and we can't find a UTI, we're going to tell you we want to look in your bladder. Pain during urination that's not explained by an infection. Again, the frequent UTIs. And what you can do to try to reduce your risk: quit smoking if you're smoking. That dramatically reduces risk. And if you've already got bladder cancer or kidney cancer for that matter, which it also can lead to, it'll reduce your chances of having a recurrence. Be aware of other exposures in the workplace, report any unusual symptoms, and after treatment, if you are diagnosed, please adhere to your follow-up protocol. There's a whole lot more I could talk about on bladder cancer. I just don't have the time today. That's another, 4 or 5 hours worth of webinars. But hopefully you guys found what we did get to go through today helpful, and I'm going to leave a little bit of time for questions.
Yes, if you haven't submitted your questions yet, be sure to do so. You can use the Q&A button at the bottom of your screen, but we already have several, Dr. Mobley. So one of the questions is really just a statement. Starts with a statement, but it's not uncommon for older women to get recurrent UTIs, even if even if they didn't experience that when they were younger, is there a reason why that happens?
Yes, that's a good question. And it kind of goes back to the whole estrogen conversation we were just having. So when you go through menopause and your estrogen levels basically decline to nothing, that changes the environment of the vagina and the urethra and the bladder for that matter. The urethra, the bladder, the vagina, they're all estrogen sensitive organs, especially the vagina. And when the vaginal tissues lose estrogen, they become thinner. And they also, there's normally bacteria that inhabit the vagina. That's a normal phenomenon. These are lactobacillus strains. Those lactobacillus strains require a very low pH to survive. Estrogen helps keep the vaginal pH low. It's lower than any other pH in anywhere in your body, around a normal pH of 4. Those lactobacillus need that lower pH to survive. Lactobacillus help fight off urinary tract pathogens. They keep the bad pathogens from being able to crawl up in the urethra and up into the bladder. So by adding back estrogen, we are able to drop the pH of the vagina back. That allows those good lactobacillus strains to come back and survive in the vagina, in the urethra. And that helps to fight off the urinary tract infections in that way by keeping the host defense mechanisms in line. If you're on a probiotic, but you're not on estrogen and you're postmenopausal, that probiotic's not going to work nearly as well because you may be taking lactobacillus, but it just can't survive in the vagina because the pH is too high and it needs that acidic pH. The other part of that is by thickening of the tissues. When you get on vaginal estrogen, it thickens your vaginal and your urethral tissues. That helps with incontinence and overactive bladder, but it also helps with UTIs because there's more resistance, it's harder for the bacteria to travel up the urethra and get into the bladder.
Awesome. Thank you. Another question we have is, I have no problem urinating during the day, but I have to wait about 5 minutes before I can urinate when I wake up at night. What might be the problem there?
Yeah, I've never actually gotten I don't know that there's a textbook answer to that, but I'm going to give you my theory on why this happens. And it may be completely wrong, but I hear it a lot, and this is just a theory. Okay. But, all muscles work or the way muscles work is the muscle fibers contract over one another. And if you're sleeping through the night and this is a presumption that you're sleeping through the night, maybe your bladder is getting a little bit more stretched out because it's holding more urine than you normally would through the day when you're urinating more regularly as you're up and about walking around. So now those muscle fibers kind of get a little bit out of alignment, and the bladder contraction is not able to happen in its most optimal way. So a lot of patients, it takes a couple times in the morning, that first hour, it's like they have to go 3 or 4 times to kind of get it going and get their bladder emptied, but then they're fine the rest of the day. I hear it all the time. So I think that might be one thing to do with it. It may just be, again, kind of a groggy central nervous system first thing in the morning, and the brain's just not sending the signal to the bladder, and the bladder's not responding properly. But that's my theory, and I'm sticking to it.
Thank you. Another question is, what do you recommend for frequent nighttime urination?
Yeah, we call that nocturia, and there's a lot of different reasons why people can have nocturia. It is one of the more frustrating things that urologists have to treat because oftentimes it's not really a urologic problem at all, i.e., it doesn't have anything to do with the bladder or the prostate, things like that. It ends up in our office a lot for obvious reasons, but the single biggest risk factor for excessive nighttime urination is sleep apnea. If y'all don't know what sleep apnea is, it's when you snore and you have these apneic episodes where you're not breathing, you're not oxygenating. A lot of people will kind of wake themselves up when they do this, or their partners will hit them because they're snoring so loud and it sounds like they're dying because they're only taking a breath every minute. That is a really dangerous problem, untreated obstructive sleep apnea. And I'll briefly go through the physiology with you here. When you're apneic and you're not oxygenating, the pulmonary blood vessels, those are the blood vessels in the lungs, constrict. Okay? You can think about it like those lungs are trying to eke out whatever oxygen they can get. And so they're like tightly squeezing around the blood that's being pumped to it from the heart. The heart, specifically the right side of the heart that is pumping blood to the lungs, is having to work hard, just like the bladder has to work hard against the prostate. So this is a very, very good analogy. the heart, a smooth muscle, it's a lazy muscle. It does not want to have to work hard. Okay. So what it does while this is happening is it secretes something called atrial natriuretic peptide, ANP. It is made by the heart and it goes directly to the kidneys. And it is like Lasix. It is a diuretic for the kidneys. It turns the kidneys on overdrive. Now the kidneys are told from the heart, make more urine. And the reason for that is to try to offload volume from the blood. So it's basically pulling all the free water it can take out of the blood to concentrate the blood. So now the heart's not having to pump as much volume to the lungs. Now, once you're up and awake and you're not apneic and you're oxygenating like normal, your pulmonary blood vessels, they expand again. The heart can relax. It's not having to work so hard anymore. So it stops sending that signal to the kidneys, and the kidneys go back to normal, and you make normal amounts of urine again. And it starts over again when you get back to being apneic when you go to bed. So it's again the single biggest risk factor for excessive night urination. If you have that problem, you absolutely need to talk to your primary care doctor to get a sleep study set up and get evaluated, see if you have sleep apnea. I'm not saying everybody that snores does, but if you have sleep apnea, it needs to be treated, because not only is that problem super annoying, but it also increases the risk for heart attacks and strokes and congestive heart failure and cor pulmonale and, pulmonary hypertension. There's a lot of reasons why you want to have obstructive sleep apnea treated. It increases your hemoglobin, your hematocrit, makes your blood too thick, increasing your risk for stroke. It can make your testosterone go down. It drops your it increases your cortisol, which creates chronic body inflammation. The list of reasons why you should get that treated and evaluated goes on and on and on. Now, there are other reasons. Yes, you can have an overactive bladder that's happening daytime or night, and some people's bladders are a little bit more overactive at night. There's something called reduced nocturnal functional bladder capacity. That's a mouthful, but certain patients, when we have them keep a diary of their urination habits and they track how much urine's coming out at night and how much urine comes out each time they void, we can see a discrete difference between the amount of urine that comes out when they're voiding during the day. Maybe it's 10 ounces, 12 ounces, 18 ounces per void. And then at night it's 2 ounces, 4 ounces, 2 ounces. So they're not urinating too much in terms of total volume, but the amount they're urinating each time, the amount their bladder's waking them up for, is very small. That's a hard problem to treat. And some people's mechanicosensors in their bladder are just much more sensitive when they're laying down in that position versus when they're upright. But that's one reason. Some people are over drinking in the late afternoon and the evening, especially things that are known to be bladder irritants. And that's creating more urine at night. That's polydipsia, drinking too much, leading to polyuria, urinating too much. And then again, some people, it's this obstructive issue like with their prostate, or if they've got prolapse, or it's their diabetes, or maybe they didn't realize it, but they're taking their diuretic late in the afternoon or evening. Some patients have really bad peripheral vascular disease. They get swelling of their lower extremities, and their legs get swollen during the day, and they realize in the morning when they wake up, their legs are not as swollen. Well, they probably are urinating a lot at night when that's happening, because when you lay down flat and your legs are now level with your heart, that's the chance your body has to pull all that extra fluid out of the extravascular space back into the blood vessels, circulate it up to the heart. The heart then kicks it out to the kidneys. The kidneys are working overdrive at night, trying to pull all this extra water off so they can start the day again and not be, look like the Michelin Man. So that's another one. And if you've got peripheral vascular disease and lymphedema or lower extremity swelling, if you're noticing that happening, it's best to, number one, wear compression stockings throughout the day. But number two, prop your legs up sometime in early afternoon for an hour or two, if you can, if you have that luxury, and let your body start processing some of that fluid overload before bedtime. Then you will only, you won't have quite as much that your kidneys are trying to offload at night.
Thank you. We probably have time for one more question. There's a couple with this topic. So just recognizing there's been slight leakage during the night, or actually, not waking up and having leakage. And so sleeping through the leakage, should they be concerned is the question, and maybe what should they do?
Yeah, I mean, definitely, if that's it's a quality of life issue for a lot of people. You know, this is sort of taking out the subset of patients where we're maybe talking about overflow incontinence, where they absolutely need to be seen. But if this is just an intermittent issue, it's a hard problem to deal with when it's happening so infrequently, because a lot of the treatment options that we have are something that have to be kind of maintained on a daily basis or done very regularly. And some people will come in and say, look, this is bothering me so much. It may only happen twice a month, but when it happens, I'm so embarrassed and it's affecting my relationship, whatever. Those are all valid issues. And we try to work with that patient to find a solution that's going to work for them. Most of the time, it may be, unless they're like a really rough sleeper and just coughing a lot when they're sleeping or tossing and turning, that might be more stress incontinence. But if that's not the case, it probably is a little bit more urge incontinence. Their bladder's getting a little full while they're sleeping soundly, which is great, but their bladder may be starting to squeeze while they're sleeping because it's getting a little too full. Like normally during the day, they would have already been conscious enough to have the signal that, oh, I need to go use the bathroom. So we treat it most often more like an overactive bladder, and those therapies work quite well for that. But, you know, look, I have some patients where they're wearing 3 pads a day. They're happy as a clam, you know, and I have some patients that get 1 liner wet per week and they are super frustrated. And those are all valid. You know, we just have to meet the patient where they're at and figure out what's the best treatment for them. You know, a lot of this is a quality of life issue, and there's nothing that we are mandating about their treatment protocols. We're working with them to find a solution that's going to, you know, be amenable to their lifestyle and kind of their desires. But happy to evaluate anybody for it, and then we can try to come up with a plan based on what they're really looking for and what their goals are.
All right. Well, thank you, Dr. Mobley. This has been super informative. I know we've helped a lot of people this evening and answered some great questions. Is there anything, just closing thoughts that you have? If not, we can close out.
No, I think we did a good job going through it, and hopefully we'll get to do it again sometime.
Great. Well, thank you everyone for joining. And you can visit urologyaustin.com to schedule an appointment. So any of these items that challenges that Dr. Mobley discussed tonight is in your mind. It's always great to get a checkup. So visit urologyaustin.com and
I'll say one thing. I just put this up. I'm Dr. Mobley, of course. My PA is Martha Serenana. I'm at the Atrium office, our Central Austin location in Cedar Park. My PA is there with me in those locations and also up in Georgetown. So, you know, we're happy to see any of you guys or ladies to help with this problem. We got lots of other physicians in the group that can also address these issues with you. So if any of that sort of caught your attention, you know, please give us a call or look us up.
All right. Thank you so much. Have a good evening, everyone.
Thank you.